You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to this episode of the Addiction Files. We are thrilled to have Dr. Javier Ballester back joining us to talk about the neurocircuitry of addiction. This is one of my favorite topics, but I don't know enough about it. So we are just going to talk to the expert. So Paula is going to introduce Dr. Ballester for us. And I'm going to turn over to Paula now. Thanks.
Okay. Well, for those of you who listen to the podcast, you will recognize this guest. He was on episode 46 of season 3. He was our season opener for season 3, and he discussed the methamphetamine fentanyl epidemic. And honestly, it's one of our most popular episodes. So thanks again, Javier, for being on the podcast for that episode. It was so interesting, and I can see why it's one of the most popular episodes. So people are super lucky to have you back, and we're super lucky. And in terms of an introduction, Javier Ballester is an addiction psychiatrist, and he is the medical director of the Salt Lake City VA Substance Abuse Residential Rehabilitation Treatment Program. He was born in Zamora, Spain, and grew up in Ciudad Real. I had to practice that. I get kudos if I got it right. This is a little town in La Mancha where the Manchego cheese comes from and where the famous El Quijote book from Miguel de Cervantes takes place. That's cool. He went to medical school in Madrid, and he did his residency in psychiatry in Madrid as well. And then he came to the USA and did a fellowship with the Alicia Koplovich Foundation and spent 2 years in Pittsburgh studying child and adolescent psychiatry. Then he went and did a residency in psychiatry at Yale. And then he also did an addiction psychiatry in fellowship. So for all of you who are in residency or fellowship, don't complain, because Javier has done residency and fellowship, right? That's right. You've done residency twice, fellowship twice.
That's correct.
So you're very well educated, and we know that when we talk to you, and we're very lucky to know you. Javier's interests are teaching and the applicability of neuromodulation and addiction. So thanks for joining us. We're very excited for this episode, and we're going to talk about the neurocircuitry of model of addiction with you today.
Thank you so much, both of you, Darlene and Paula. I am very excited to join you. Thank you for inviting me again. And this is one of my favorite topics. So I am going to try to do my best to explain some concepts here. And this is a work that is never finished. It always continues moving forward, and is the result of a lot of people and decades of research. So I am also very excited. I'm going to try to do my best to explain.
Well, we're excited, and we feel confident that you're going to do a good job, because I've heard you lecture, and so has Darlene. And so you got it.
Thank you. So before anything, I recognize the work of two very famous scientists, and one of them is Nora Volkov, who is currently the director of the National Institute on Drug Abuse, or NIDA, and she has been working there since 2003. And this is the result too of her work in the 80s and the 90s with positron emission tomography, which is a neuroimaging technique in different research centers across the country. And this work is also it's been developed by George Cook, who he is the director of the National Institute on Alcohol Abuse and Alcoholism since 2014. And he described this neurocircuitry model of addiction already in a book that he published back in 2006. And the title of this book is Neurobiology of Addiction. with another scientist called Michel Lemol. And his research comes from animal models of addiction, mostly with rodents. So we have two branches here. We have one humane clinician, Nora Volkov, and then we have a basic researcher who is George Coop. And the nice thing about the neurocircuitry model of addiction is that both National Institute of Health institutions, NIAAA and NIDA, come together to explain this. And a lot of the information that I got to explain this comes from two papers. One of them was published in 2010 in the journal Neuropsychopharmacology and is called Neurocircuitry of Addiction. And another paper was published, it's kind of like an update, in 2016 in the journal Lancet Psychiatry, and it is called Neurobiology of Addiction and Neurocircuitry Analysis. So both papers provide a good summary for those listeners who are more interested in getting more information about this. So the neurocircuitry model of addiction explains in general addiction, or better, this dissects addiction as a multi-stage process that can be divided in three different stages, and all of these stages occur in different areas of the brain and explain different psychological phenomena too. So we can start by saying that there are three different stages, and it's important to know that not all of these stages are not sequential. So all of them happen in more or less degree at the same time in the brain. And some people will, depending on their predisposition, some people will have the involvement of one of these stages more pronounced than other ones. But in summary, we are dealing with three different stages. And the first one is called binge intoxication. That's what they describe. And this information, for those of the listeners who are interested, we can find a good description of this stage on a paper called The Brain on Drugs, From Reward to Addiction, that was published in 2015 in the journal Cell. And this is the result of Nora Volkov and Marisela Morales. And what this stage summarizes is, I'm going to start to provide a little bit of basic information. And it is important to first highlight that in order for any substance to produce or to have the propensity to produce addiction, all of the drugs must increase the levels of a neurotransmitter called dopamine. And that happens, well, directly or indirectly. But the ultimate road needs to be the increase on dopamine. And dopamine is a neurotransmitter, or other people even consider that it is a neuromodulator because it doesn't work fast. It works slowly. And it is a neurotransmitter that is involved in a lot of functions in the brain. So it is very much involved in movement, regulation of movement, and it is as a consequence, when it is deficit, it can produce a disease called Parkinson's disease. But it is also involved in motivational processes, and this is coming from a different route in the brain. So the main neurons that produce dopamine, that are involved, when the dopamine is involved in these motivational processes and reward processes, the neurons come from an area of the midbrain called ventral tegmental area. And so this area has the soma of those neurons project to different brain regions. And these regions are important for some very important processes such as motivation, like I said, but also emotion regulation, attention, and cognitive control. So they project to different areas of the brain from the ventral tegmental area, and those areas examples of those areas are the basal ganglia, the amygdala, or the prefrontal cortex. And this is through a pathway called mesocorticolimbic. It has like a long name, but it's basically depending on the psychological function that we are considering. The neurons are projecting to different brains. So dopamine is released in two different ways in the brain. There is a tonic way, which means that it's constantly released. And there is also another way that is called phasic. The tonic way is between 1 to 8 hertz. So it's 1 to 8 times a second. And the phasic way is more than 15 hertz. So it's produced more than 15 times a second. And the difference between both is that the phasic way produces high increases in dopamine in the synaptic space. And the synaptic space is that space by which two neurons communicate one to each other. It is thought that this phasic way is in charge of signaling those stimuli associated with rewards. And this is called conditioned stimuli. So for those people who don't know, conditioned stimuli, when we talk about this, we can think about the classic experiments of Pavlov and the bell and the dog. And the bell in this case is a conditioned stimuli because the noise of the bell was paired to the delivery of food. So the dog started to salivate as soon as the dog could hear the sound of the bell. So that is a conditioned stimuli. And the phasic fast release of dopamine is involved in signaling those stimuli. So all of this was discovered by a scientist called Dr. Solz, or Wolfram Solz, at the beginning of the 90s. And this was synthesized and first published in a journal, in the prestigious journal Science in 1997, on a paper called A Neural Substrate of Prediction and Reward. And what this scientist did is he was placed electrodes in the brain of monkeys, and he could measure in vivo the release of dopamine by something called microdialysis. So basically measuring the concentrations of dopamine in the synaptic areas of the brain. And he was able to demonstrate that the levels of dopamine in monkeys will increase when there was a stimuli that will predict the delivery of a reward. And he called this that a signal prediction. And this is very contrarily to what a lot of people think, that out there, people normally think that dopamine is involved in pleasure, and it is somehow too involved in pleasure, but it's not only on that. Dopamine is also involved in all of these stimuli, all of these conditioned stimuli, and especially those that are important for the survival of organism. So, for example, the availability of food or sex, all of that increases the levels of dopamine. Also, when there is a delivery of an unexpected reward, that also increases the levels of dopamine, with the idea that that new stimuli will be paired in the future and will become predictive of a further delivery in the future.
So interesting. So it's really an anticipatory neuromodulator or neurotransmitter, and then it's also and a learning and motivation neurotransmitter, right? As opposed to what we simply and historically have thought about it as just pleasure. It's not only pleasure; it's more anticipation and learning.
Exactly. That is a very important thing to know, because dopamine is very much involved in learning, and it is very much essential and central in some processes called long-term potentiation, and which are processes that are involved in plasticity in the neurons. So through dopamine, there is new connections and long-term connections between neurons are going to be facilitated through this process called long-term potentiation. Like I said before, all drugs of abuse, they need to increase the levels of dopamine, and if there is no such a thing, then there is no drug of abuse. There is no possibility for that. That is why not every substance in the world can become a drug of abuse. It has to have that basic property. And the interesting thing to know is that drugs increase the levels of dopamine quantitatively in hundreds or even thousands of times higher than the natural rewards produce. So as we can imagine, there is going to be a very, very deep process of learning that will be ingrained for many, many years. And that is one of the problems of addiction. And that is one of the problems too that explain why people can suffer from return to use after decades even of becoming sober, because those circuits have been so ingrained by dopamine and other neurotransmitters that are there connected, reinforced. Should I continue?
Yeah. No, that's really interesting.
Okay, I'm trying to make it a little like, if there is anything that it doesn't, I'm trying to make it understandable. Okay, so another to make it a little more complicated, the ways for which dopamine works in the brain, in the basal ganglia, in this area of the brain called basal ganglia, there are two different pathways by which dopamine works. One of them is called direct pathway, and another one is called indirect pathway. And this is very well described, the control of movements. This is something that we had to study when we went to medical school to try to understand what happens when there is a degeneration of the dopaminergic projections, in this case, from the substantia nigra to the dorsal basal ganglia. But it happens that these both pathways, direct and indirect pathways, are also involved in the circuits of motivation that I am trying to explain. So it's not only about movement, it's also about other processes. In this case, through this mesocortical limbic pathway coming from the ventral tegmental area. So the possibility or the classification of direct or indirect pathway has to do with the presence of two different types of receptors. Receptors are those places where dopamine works in the neurons. So there are two different families of receptors. There is one family called D1 or D1-like, and there is another one called D2 or D2-like. And D2 family of dopamine receptors are involved in the indirect pathway, and D1 type receptors are involved in the direct pathway. And it is thought that the direct pathway is involved more in this expectation of reward, while the indirect pathway is more involved in punishment and and it is important then to know that both D1 are excitatory receptors and D2 are inhibitory receptors. And D1 receptors have very low affinity for dopamine. So they will only be activated when there is enough increase. When I was talking before about this phasic increase in dopamine levels, that phasic increase is large enough to activate this D1 direct pathway, and that is associated to reward. When the dopamine is released in tonically, more in a constant way, then it can bind to the D2-like receptors. And these receptors have a lot of affinity for dopamine. It is not like the D1. And that's why when there is not enough dopamine, or when it is released tonically, only the D2 or indirect pathway will be activated. And people might think, okay, well, if this is involved in punishment, how is it possible that tonically this punishment is involved, right? So, but what it's important to know that D2 are inhibitory. So when the regular baseline motivational processes, the D2 indirect avoiding punishment, it is what it is activated. And that is what explains our basic motivational processes. I don't know if that's clear.
Maybe, Javier, just for our non-medical listeners, explain the difference between like excitatory and inhibitory.
Okay.
So what does that mean?
That's important. Yes. Thank you for reminding me. So something excitatory means that the neurons where the dopamine is binding to, those neurons are going to be activated. So are going to start to fire, and they're going to start to basically fire. So in order for people to understand, while inhibitory, what it's going to do is going to produce changes that is going to lead to those neurons not to fire, not to be activated. So that's the difference between something excitatory or inhibitory in the brain. So imagine like electricity going through cords. So something, if you bind two pieces of cord, if it's excitatory, you are going to have electricity. But if one of them is inhibitory, you are not going to have electricity. So it's basically something like that.
That's great. That really helps.
Then a couple of more things to know about this binge intoxication stage is that, like I said, this is happening in an area called the basal ganglia, and that is like in the middle of the brain, deep structures in the middle of the brain, and one important thing to know is that those changes, like I said before, in dopamine are going to be long-lasting by those processes that I said before that are very important in learning, called long-term potentiation. So when we also talked before about dopamine being involved in pleasure or not, it's very important that we have to mention two scientists that have been working on this at the University of Michigan. They are called Robinson and Berridge, and they published in 1993 a theory called incentive sensitization. It sounds a little complicated, but it's not really. What it means is that those stimuli that I was talking before that have predictive value, signaling a reward, they ultimately, because there is so much dopamine, because they are being activated so many times, they become sensitized, those stimuli, meaning that they will have more powerful to signal the prediction of the reward. But more interestingly is that those stimuli can become attractive by itself. So the mere presence of this stimuli can be rewarding for some people, not as much as the drug per se, but even just the stimuli. And that's why it's called incentive sensitization, because the stimuli become sensitized, but also it become incentivized. So that's what the theory tries to explain. And this is a very good theory because it also works explaining why on some addictions that are not where drugs are not typically involved. So I'm just talking more about gambling disorder. It explains why in gambling disorder it has been demonstrated that you have alterations in dopaminergic circuits, and it helps to explain how you can become addicted to those powerful stimuli that are environmental without even the need to use a substance to increase the levels of dopamine.
So interesting, especially since recently we've had a guest discussing porn and sex addiction, and another guest, Dr. Medika Kanaba, discussing addictions of gaming and gambling and phone, and then another guest, Catherine Van Tassel, about food addiction. I mean, food, I guess, is somewhat mixed because it's also a chemical in a lot of ways, but those other process addictions, this explains the process addictions, right, that Dr. Alex Katahakis and Dr. Kanaba talk about. So that's fascinating.
And this incentive sensitization also helps to explain why stressful situations might lead to a return to use in the drug, because we know now that stress is related with increases in dopamine too. So if you have already something that is sensitized, you might activate the whole circuit just by stressful situations. So in that regards, I think that this theory helps explain these concepts too very well. Finally,
Javier, can you just talk about that a little bit more? Because this is really important. So, because so many people return to use under stress, right? Like, I'm amazed sitting in clinic in all of January, and I know you and Darlene are hearing the same thing. We're hearing lots of people talk about how December was so stressful and the holidays, and a lot of people had a return or an increase in use. And also, the stressors of a cold winter. So can you explain it one more time? Explain it to me.
So stress is one of the most powerful reasons why many people return to use drugs. And I'm going to be talking now in a few minutes about the next stage that can explain this very well, called withdrawal negative affect. But it is also important, at least from this binge intoxication stage, through the incentive sensitization theory, we know that stress produces increases in dopamine. This is another argument why to consider and to take into account that dopamine is not only about pleasure, it's more about marking important things for survival. So it has been proven many times that even in animal models, that when you expose an animal to a very stressful situation, for example, the presence of a predator in an animal like a goat, it has been demonstrated that stressful hormones increase in those situations, of course, but it has also been demonstrated how animals can return to use drugs under those stressful situations. And that can be explained by many reasons. And one of them is through this incentive sensitization. But another reason is going to be now when I talk about the withdrawal negative affect stage. So the last important piece that I wanted to talk is that there has also been another recent, not so recent, but recent discovery is that, and I'm talking about this stage, is that the ventral tegmental area, this area of the brain of the almost at the top of the brain stem and the floor of the diencephalon. So this area is involved, the ventral tegmental area is under control somehow of also among different areas, is under control by the prefrontal cortex through different projections of the prefrontal cortex, glutamatergic projections. But one of the things that people, more basic researchers, they have been able to find is that through the development of addiction, when dopamine is involved more and more, there is a transition between a more let's say, controlled way of using drugs to a more habit or automatic way of using drugs. And it has been demonstrated that this is also through dopamine, but there is a transition, and the areas that are activated, it goes from the ventral tegmental area to the substantia nigra, which is an area that is involved in movements, and that is not under prefrontal cortex modulation. So this is kind of like a neuroscientific evidence to explain why in the long-term effects of addiction, a lot of people end up using drugs in a more compulsive way. So they say it transitions from a more impulsive to a more compulsive way. So it becomes more habit ingrained, it becomes more automatic. And one of the theories is that there has been a transition in the dopaminergic pathways from a more ventral tegmental area, which is the normal way of motivation, to a substantia nigra, which is more movement type and less under control. And that goes also from the ventral part of the basal ganglia to a more dorsal part that is more involved in habits.
That is so interesting. And I think we could all say, you hear that in our patients' histories, don't you think? Because they'll come in and they'll tell you that they don't even remember or know what they're doing. It's just, it's like you just said, Javier, like it's almost that automatic behavior, and they don't even know what's happening. But that makes total sense the way you're explaining that, what's going on in their brain.
Yes, they might even have problems identifying that this is something that we will talk at the end, but they might even have problems identifying that that is becoming even a problem. So it is just, it gets, it gets worse. It gets more out of our own even awareness of this is a problem. So I think that this is an important concept, and I was very surprised when I learned these findings, that how addiction can become more compulsive and more automatic, and possibly then less responsive to treatments in the long term.
I find that so fascinating. I mean, and it just kind of makes sense with what we see.
So maybe we can now move on to the next stage. It's called withdrawal negative affect. And that's the second stage. And the first stage, Dr. Volkov is more, provided more input and more information. This second stage, Dr. Cook provides and has more data and more information. It's kind of like his area of expertise. And it is very important to know that this stage happens, we are moving away from this basal ganglia part, and now we are moving away to another area of the brain called extended amygdala. And this area is, if we think about the basal ganglia more in the middle part and deep part of the brain, this is moving a little bit more to the lateral, so more to the temporal areas of the brain. And it's very hard to explain without a picture. So I encourage everyone to look into any of these papers that I mentioned before, and they can see where it is located at. And this is this stage helps to explain why a lot of people use drugs, not only due to a positive reinforcement, which the previous stage helps very well to explain that, but also a lot of people use drugs because they want to feel relief from negative emotions or from stress. And that is what is called negative reinforcement. So positive reinforcement in classic psychology is kind of like when you get a reward and you work hard to get that reward, that work gets reinforced, and that is called positive reinforcement. But there is also another side of reinforcement that is called negative reinforcement. And what that explains is you work to get away from to get away from a situation so people can understand from an undesirable situation. So in this case, from withdrawal symptoms. So a lot of people use drugs, and ultimately we could even say that the majority, if not all, of the people who become addicted to drugs will end up using drugs to escape from this emotional stage. And it's not as much as trying to get any reward from them or trying to get this high that was more associated with maybe the very beginning of the first stage, but it's more about not feeling miserable. And I think this stage applies to a lot of the drugs that are more what people call downers. So opioids, alcohol, benzodiazepines, those drugs are very, very well associated with this stage when the drugs are not present anymore. But ultimately, all of them. But this, especially to me, is very much more applicable to the downers than the other ones. George Cook talks about a classical theory, a classical process called, and he wants to differentiate between homeostasis and allostasis. This is a little difficult to explain, but I'm going to try to do my best. So in our bodies, we have a lot of processes there that are very primitive, and there are a lot of processes in place so to maintain an equilibrium in the body for essential survival functions. For example, when the oxygen levels drop, then the body's response is trying to improve and trying to activate breathing so you can breathe faster or even deeper so you can get the oxygen up again. The same thing happens with other processes that need to have an equilibrium, like, for example, pH, the pH in blood. We need to have a constant pH in our blood, because otherwise the main chemical reactions will not take place. And so that needs to be very tightly regulated. And there is a lot of chemical, they called buffers, that are activated when the pH gets deviated. So all of this is explained through homeostasis and homeostatic mechanisms. And they basically work through feedback. So there is a sensor that in the body that notices that there is a deviation on the equilibrium, and what that happens is like a danger signal, and then this buffer and these systems start to get activated to reach back this homeostasis. So this is called homeostasis. But there is also another process that is also regulation, and it's also equilibrium, but in a different way, and that is called allostasis. And it's different from homeostasis for two reasons. One, because it requires changes in the body to continue the equilibrium. And so people can understand this. For example, when you have people exercising and you have, let's say, lifting weights, your muscles are going to get bigger. And that is because the body senses that there is a perturbation and that you require more strength to deal with your environment. And as a consequence, your muscles get bigger. So you still want to get an equilibrium, but you maintain the equilibrium through changes. So that is the main difference between homeo and allostasis in this case. And allostasis is not as much as feedback, but it's more about feed-forward mechanisms. And it's important to know that in our brains, when we talk about learning and about changes, most of the things that happen in the brain are allostasis, because we are always, we are never the same. We are not the same as when we were children. And every day we could argue that we are a little bit different because something has been changing in our brains and we are not exactly the same molecules that we were the day before, right? So this is through processes of allostasis. So why do we talk about this? Is because when it's important for people to know that the use of drugs is actually something very stressful for the brain, and that is because drugs are gonna lead to a lot of changes happening. So one of the things when I was talking about the dopamine levels, what I said before is that the increases on dopamine levels produced by drugs are in the order of hundreds or 1,000 times bigger than the nature will produce, and so that is perceived as a complete abnormality in the brain. It's something that is not normal. It's a total perturbation of what is supposed to happen. So that is going to activate these allostatic mechanisms. And this theory, it was proposed by Dr. Salomon already in the 70s, is used by George Cook to explain why the use of drugs in general leads to changes in the brain and to perturbations called process B, whatever. But it's important to know that George Cook distinguishes between changes in the brain produced by the use of drugs, and that can explain, and he differentiates two types. Within system changes and between. Within system changes are those changes that are produced in the dopamine pathways that I explained before. So what happens is that the levels of dopamine get so high that there is going to be changes in those D1 or D2 receptors in the neurons. So there is going to be changes so the neurons don't get as much or as less stimulated by this. So there is going to be changes in the number of receptors available. So in other words, is the development of tolerance. And this can be very well explained by the use of drugs, and explains why when we are using drugs, the same levels, the same amount of drugs do not produce the same changes anymore. You need to use higher and higher doses to get the same degree of activation that you used to get before. This has been demonstrated in animals and in humans. And in this case, in neuroimaging studies in humans, they have been able to demonstrate that when people are having withdrawal symptoms to drugs, or even in that stage that you have talked before called protracted withdrawal, if they give a substance in those subjects, a substance like methylphenidate, which is it releases dopamine under normal circumstances, they have been able to find on people with cocaine use disorder, but also with alcohol use disorder, that the levels of dopamine that methylphenidate can produce is lower when they are having protracted withdrawal. And how is this possible? But it is because there has been these within system changes. So the levels of dopamine are not as high as they should be before. So this has been demonstrated, like I said, in animals and in humans. And
Javier, I have a question.
Yeah.
How long does that last? Is it last for however long the protracted withdrawal is being experienced, or is it go on even beyond that?
I would say that definitely during this protracted withdrawal symptom. So it might be, at minimum, it's going to be days, if not weeks. But it might be those changes in the dopamine levels might last for months, and that is gonna be that has been shown in different neuroimaging studies, and that is going to depend on individual reasons, on the amount of drug that has been used, for how long the drug has been used. So there is a lot of biological factors that explain these lower levels of dopamine than people are going to have. And the clinical consequence of this is to explain this lack of motivation that people suffer with when they are withdrawing and when they even stop using drugs. So the levels of dopamine used to be so high in the past that now natural rewards are not going to produce the same. So people feel like this feeling that things are not as good as they used to be. That is called anhedonia, or hypoedonia. And basically it's that natural rewards are not as stimulating as they used to be before the development of addiction. So this is the within system changes. And there is also a between system changes. And this is where the extended amygdala plays a role. So like I said, the drug use is stressful for the brain. So this is going to lead to any drug in general. And there is a lot of research in that area because there might be even immunological reasons why there is release of stress hormones in the brain. But drug use leads to increase in stress hormones such as CRF and other stress hormones that are normally involved in stressful situations. So it has been demonstrated that the chronic use of drugs is going to lead to increases in CRF in areas such as the amygdala. So, and extended amygdala. And so what happens is that the extended amygdala is very well positioned in the brain, and it connects to areas of reward, but it also connects to autonomic areas that are responsive to things like heart rate control, like blood pressure control. And so all of these stressful situations are going to lead to and it has also been proven that the withdrawal from drugs in general, especially the downers, there is, the extended amygdala starts to fire up and produces or explains some of these withdrawal symptoms that people suffer with when they stop to use the regular drug that they used to. So these between system changes can explain very well this self-medication hypothesis of why people use drugs when they are under stressful situations, because they are trying to modulate and to tamper down this extended amygdala overactivation. And I think that this is also important to know because this area of the brain can also be activated by many other things. So, for example, past trauma has been proven to sensitize this area of the brain and to become more responsive. But, and other things like longitudinal experiences and neglect and genetic influences can explain why people are more reactive. Some people are more reactive in the extended amygdala than others.
And this is also why, well, I don't know if this is why, maybe you can answer, but why finding now that medications which tend to calm down the extended amygdala response on the autonomic nervous system may be helpful for people in protracted withdrawal. So we're using more medications like alpha adrenergic agonists like clonidine and prazosin and things like that. Not specifically because we need them to have blood pressure lowering, but just because it helps with that effect. Do you think this is why?
That is very true. And there is a communication, bidirectional communication between these autonomic centers and the amygdala. So that might explain on things like alcohol use disorder, there might be positive effects of using things like prazosin, which is a drug that is normally it used to be used in the past for blood pressure control, but not anymore. But why prazosin can improve symptoms in things like alcohol use disorder that has nothing, well, it has actually something to do with blood pressure regulation, because we know also when people have an alcohol use disorder, especially if they are in withdrawal, the blood pressure is going to be all over the place. But it's not only about autonomic, it's also about the feeling and about the stress. And for example, we know that on people with post-traumatic stress disorder, they can get some relief by drugs such as prazosin. And that is thought that prazosin kind of like tempered down this hyperactivation of the amygdala, and that can lead to have less activating dreams than they would. So we talk about CRF, which is one of these hormones that is involved in stress and is involved in the release of cortisol, but there is other neurotransmitters that are important. So, for example, there is one called dynorphin, and this neurotransmitter is expressed in different areas of the brain, and it has been found that is increased. The levels are increased after chronic drug use, such as cocaine. And what it does is decreases the activity of the dopaminergic projections through a different type of receptors. And there is other. We talk about these stress hormones, but there is also, to make it more interesting, there is an anti-stress systems in the brain. So we are equipped to also have anti-stress when we were talking about buffers before in the brain. So this is through some neurotransmitters, peptides called, for example, neuropeptide Y, but also endocannabinoids or nociceptin. Those are mechanisms in place to try to regulate stressful or high stressful states in the brain. Conclusion, just to summarize this negative affect stage, we can say that the development of these aversive emotional states can lead to continued drug use. And this could be the result of an increase in these stress systems, like I said before, like CRF in the amygdala, or anti-reward systems like dynorphin, like that I explained before, just very briefly with cocaine. But it could also be by deficits in the anti-stress systems, like deficits in endocannabinoids or neuropeptide Y. So that explains also, this is complicated, but that explains how people can have alterations in this stage through different pathways. And finally, go ahead.
Sorry. Oh, thank you. That was really helpful.
So the last stage is called preoccupation anticipation stage. And that stage is focused in those changes and the role that the prefrontal cortex has in the development of addiction. The prefrontal cortex, so people know, is an area of the frontal cortex that is behind our foreheads and above the eyes. And it is a very important area because it's involved in many functions that are essential for our own functioning. So self-control, emotional regulation, motivation, attention, working memory, decision-making, salience attribution. So all of that is, prefrontal cortex has a major role there. So in 2001, Rita Goldstein and Nora Volkov, they proposed a syndrome. They proposed a complicated name for a syndrome that might explain what happens in addiction in the prefrontal cortex. And they called that syndrome impaired response inhibition and salience attribution.
Right.
So basically what happens is that because of those changes that happen in the prefrontal cortex, there is going to be bias, and the prefrontal cortex is going to be more interested, let's say, and it's going to give excessive importance or excessive salience to drugs and drug-related cues, and as a consequence, decrease sensitivity to non-drug reinforcings. But also, at the same time, there is going to be an impairment in the ability to inhibit those behaviors that are not good for us. So that is what the impaired response inhibition and salience attribution tries to explain. So very briefly, different neuroimaging studies have demonstrated that there are two networks in the prefrontal cortex important for addiction. One of the networks is called the dorsal network, and it's in, there are areas there like the dorsolateral prefrontal cortex or the dorsal part of the anterior cingulate cortex, or even like the inferior frontal gyrus, but that's less important. But that network, what is important to know is that network is involved in higher order, what they call higher order cognitive function. So basically things like inhibition of maladaptive responses and emotion regulation. So kind of like one of the functions will be to try to let us be less impulsive. So we can inhibit those responses that are not in our own advantage. The other network that the neuroimaging studies have demonstrated is called ventral network, and that has areas such as the medial orbitofrontal cortex, the ventromedial prefrontal cortex, and the ventral anterior cingulate cortex. And this last network would be involved in automatic processes, emotion-related processes, such as salience attribution, which is like us giving importance to things, right, that are important. So what these researchers talk about is that in a healthy brain, the non-drug related functions and emotions in general predominate, and the automatic responses to drugs are suppressed. That's what a healthy brain would do. So, for example, if a person is exposed to drugs and there is no intention to use drugs, for example, because there is going to be adverse consequences to the use of those drugs, like let's say, if I get drunk tomorrow, I'm not going to be able to go to work, so I'm not going to go and get drunk then there is a stop signal, what they call a stop signal. And that is basically from both places. So there will be the dorsal network is involved in the ventral network and is saying, hey, stop there. Don't use drugs, don't use alcohol or whatever, because tomorrow you're going to have problems. So don't do that. And in an addicted brain, however, especially during craving or during withdrawal, all these thoughts that are related to the use of drugs at the expense of non-drug thoughts are going to predominate. And what neuroimaging has shown is that the ventral network becomes more activated and more powerful, and not so much the dorsal network. So especially when people are exposed to stimuli or to drug cues, these areas are different. So the ventral area is going to be very activated, and some people even relate that to the experience of cravings. And the dorsal area, however, is going to be inhibited. So what these researchers say is that the stop signal that I spoke before about, that I talk about, is compromised, and there is instead a behavior that is called go. But go with a interrogation. It's a go behavior, kind of like, should I do it? That is what is going to predominate. And during intoxication, so when there is active use of drugs, there is a complete interruption of this dorsal network, and the ventral network takes over. So there is not only a go with an interrogation. In this case, there is a go with an exclamation. So it's not about go, but it's more about go. So do it. So the drug-related stimuli becomes then almost the only thing that the brain is thinking about at that time. So this has been shown in people with fMRI studies, like I said before. So these areas, people with addictions, it has been shown that these areas, when they are not using actively drugs, when they are like in sobriety, but soon after in this protracted withdrawal, these areas like the ventral network is going to be lighting up when exposed to drug cues, and that has been correlated with craving measures. But this is very interesting. That was even correlated with the drug use 3 months later. So the lighting up of these areas might even predict why some people will be using drugs later in the future. Again, this is just correlation. This is not a definitive thing that is going to happen. So another study, also in people on early abstinence, showed in this case on people with cocaine use disorder, showed that non-drug stimuli that are very powerful for all of us or for anyone, such as money, is not going to lead to the same level of activation than controls. So it's kind of like their brain has become desensitized to in this case, to money and to normal like rewards. Another study, for example, using IV cocaine in people with cocaine use disorder, this is very interesting. It showed an improvement in this inhibitory control done by different tasks. And there was kind of like a normalization in how these areas work when people were actively using. So it's kind of like then people sometimes might be using so they can normalize the way that the brain used to work before, in this case, the prefrontal cortex.
So, okay, let me make sure I'm understanding that. So when they're actively using, so they are not having that that VTA isn't hijacking the prefrontal cortex, basically. Am I understanding that right?
So one of the things that they have, and this is kind of like a connection with the first stage, is that those changes that I explained before in the dopamine receptors have been correlated with the degree of activation of the prefrontal cortex. So for one reason or another reason, the prefrontal cortex is not going to be working the same as it used to be before. So that has been proven in people when they are not using, but they are having protracted withdrawal symptoms maybe, or in early abstinence, they can see that natural rewards do not activate those areas of the brain. However, conditioned stimuli or stimuli associated with drugs will activate the ventral network in a way, in a excessive way that not healthy controls would have, and it will and the dorsal network that I explained before is not going to be working. So it tries to explain why, under normal circumstances, it's very difficult for people with addiction to regulate their habits and the use of drugs because their prefrontal cortexes are not working as they used to work before, inhibiting automatic responses and probably even planning for the future.
It's just completely offline, is how we've described that. Yeah.
Yeah. And the very last thing to understand in this process is that there has been changes not only in the prefrontal cortex, but also in areas which are very connected to the prefrontal cortex, such as the insula. So the insula is an area that we have in the brain that is very much involved in detection of integration and detection of autonomic visceral information, but also with insight. So what you feel inside, and it's very much also involved in insight and realizing and perceiving emotions too. So not only these prefrontal cortex areas that I explained before, but also the insula suffers from changes. And that might also explain why people with addiction, especially in the later on, they have a problem identifying the consequences of their behaviors. So they cannot have the insight into what's happening to them. So some people even call that like anosognosia or difficulties identifying the disease. So a lot of people with addiction end up even, we know that people with addiction, they don't learn from punishment because they cannot even identify that is even going to be a problem. So you are going to be incarcerated if you do this. And it's like, they cannot even perceive that is going to be an adverse consequence. So it's a very interesting mechanistic way and controversial because, of course, like we will have then some debate about what is free will and where is free will at. And that is another more philosophical conversation, I think.
But that is a really, really fascinating concept, Javier, because I think we see this all the time with our patients where we don't understand particularly when it's causing devastating effects on their health. It's not just the legal consequences that we see over and over again with our patients, but the physical consequences. And you just keep thinking, why do you keep doing this? But it's like you said, that concept is just their brain. It's not computing. this is not even making sense to them. So that's really fascinating.
Yeah, that's a very, very...
I think that's good for us to understand.
Yeah, that can be, and of course, this is a matter. Is not an all or nothing. There are different degrees of insight. There are different degrees of understanding. So it's a very, very complicated. But at least it helps us to understand that those things that we see in people are actually happening in their brains. So it is happening in an organ of the body. And I think that is a very important thing for us to understand. I think that can also help the stigmatizing a lot of guilt that is associated with addiction in general. I think that a different discussion is should people have adverse consequences for their drug use or not? So then we get into a more philosophical discussion about society rules and all of that. That I'm not talking about any of this. That's a different philosophical. I just also want to let everyone know that we are not only biology, but we are also, so we are biology, but humans are not only biology. I mean, they are also a product of culture, a product of development, a product of philosophy. So we are more complicated than a just single explanation about everything that happens.
Yes, that's a really good statement.
Yeah, that's really important, because we see people who beat science all the time, or they kind of defy the odds. And you talk to people with lived experience and in recovery, and they see their addiction, in spite of all these neurochemical changes and challenges that they've experienced during their period of use, they've been able to emerge out of it completely. And that's why I think there's always hope for people, even in spite of genetics, in spite of trauma and adverse child events and ongoing, even co-occurring mental illness. I think we always instill hope that people can get better in spite of all these changes. But I remember being so upset during lectures in addiction medicine, conversations in fellowship, because you just feel, oh my gosh, what's the chances that anyone's ever going to be able to achieve their goal? Like with Tiffany Love, she would give a lecture and I'd be like, there's no way anyone has a chance.
Well, I think that science helps us to understand many things, because it definitely helps understanding the development of addiction. But there is also a neuroscience of recovery. And science also explains those changes that happen in the brain when people get sobriety. And like you just said before, Paula, we never know. And when someone is going to click, and all of us have seen examples of people who are doing very poorly year after year, and then suddenly one time is the time, and then they stop using. I think that is the magic of our profession, and that is something that even science cannot predict. So I think that's what it makes us humans, and I think that is what makes things interesting and always fascinating.
Love it.
Absolutely.
But I think it's so important, Javier, to have these lessons from you and to understand the science, because we just don't come to people who are struggling with, compulsive substance use and alcohol use and expect them to just change, even when they want to. People desperately want to change, and it's so difficult. And this gives us a framework to understand why it's so difficult. And I think it's so important to understand the neurochemistry, and even for people, family members, community members, people who are not in medicine, to understand that this is really, like Dr. Volkow says, this is a brain condition. And it doesn't mean it can't be, resolved, but it really is more than just not wanting to be better or wanting to change.
Exactly. Yeah. But it's also important to know that the brain is very plastic, and it has been demonstrated over and over that intervention, psychotherapy, sobriety, medications, rehabilitation, all of that produces also changes in the brain. So in the same way that drugs produce changes in the brain, recovery, it also produces changes in the brain. So science does not provide a mechanistic, unavoidable, almost impossible way that addiction is going to happen. So that's it. You have nothing to do. I don't think no one who is serious in science would say that, but I think that it at least helps us to understand why things are way more complicated, and things like you have to do your part, and this is a moral failure, and all of that. I think that science helps to at least erase those concepts that have been so negative for generations and centuries of people suffering from addiction almost in the whole human history. So I think that is one of the things that science can give us and teaches us, and what I find very fascinating.
I love it. Yes.
Yes.
That is, and we could continue talking.
Yeah. I love it. So just recapping.
So I think the conclusion of the neurocircuitry model of addiction is that addiction is a multi-stage process that happens in different parts of the brain, and is a problem of stimuli and dopamine, and kind of like more incentive problem and positive reinforcement. And that is explained by the binge intoxication stage that happens in the basal ganglia. But addiction is also about desire to get away from all of the negative aspects that brings with it, and what George Cook calls the dark side of addiction. So it's also a stressful condition that also involves changes in the brain, in this case in the extended amygdala, and that explains all these negative reinforcement processes. And also addiction is a problem of control. It's a problem of craving. It's a problem of inhibition, and it's a problem of regulation. And that can be explained very broadly by changes in the prefrontal cortex within this anticipation stage. So kind of like what we see in clinical work is what we see in the brain. And I like the neurocircuitry model because it provides very well explanation of these three processes that relate to each other and that happens at the same time for everyone.
Love it. That, Javier, I cannot thank you enough. I learned so much, and it does. I think it helps us, like what we were talking before, decrease the stigma in addiction and just allow us to provide more evidence-based and compassionate care to our patients. So thank you. Thank you again for your time.
Thank you so much for inviting me.
Yeah, thank you, Dr. Ballester.
Thank you. Thank you.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.